Hello everyone. Welcome to the Challenges of Health Economics Outcome Research in Precision Medicine, a webinar jointly organized by the National University of Ireland Galway and the Victoria and Tasmania ISPOR student chapters. We are delighted to have you here, and we are excited to introduce the speakers of the day, Martin Wu, Dr. Caroline Walsh, and Patrick McHale. The speakers will present their experiences and the challenges they faced during the research on precision medicine. And after the three presentations, we will have a Q&A session. So please feel free to type your questions in the chat box in the meantime. Please keep your cameras off and your microphones muted during the presentation. Also, the initial part of this webinar is going to be recorded. So let's jump right in. Our first speaker is Martin Wu. Martin is a PhD candidate at the Cancer Health Service Research at the University of Melbourne. He focuses on the evaluation of the health economic impact of next generation sequencing technologies on blood cancer conditions. Prior to his PhD, he developed and managed independent research programs on genomics to drive health services implementation in Victoria, in Australia. He's currently the president of the Victoria and Tasmania ISPOR student chapter, and he received the 2021 PhD Award for Excellence in Cancer Research. Today, he's presenting a health economic model to evaluate the application of precision medicine for the treatment of chronic lymphocytic leukemia. Martin, the screen is all yours.
Thank you, Julia, for that wonderful introduction. So I'm just going to share my screen. So I believe that you can see my screen right now.
Yes, we can.
Awesome, thank you. Good morning and good evening, everyone. My name is Martin, and I'm a PhD student with the Cancer Health Services Research. And I am delighted to present today with my presentation titled Health Economics of Precision Medicine in Chronic Lymphocytic Leukemia, a Cost-Effectiveness Study. So just an outline of what I'll be presenting today, I'll firstly provide an overview of precision medicine for blood cancers. I will then move into and highlight two key issues, which I think is an issue to the reimbursement and access of precision medicine interventions for patients affected by blood cancers. I will then talk about, and this will probably be the bulk of my presentation, on the recent findings to a cost-effectiveness study on precision medicine for the treatment selection of chronic lymphocytic leukemia, otherwise abbreviated as CLL. So just to kickstart with a definition, this webinar today is all about the challenges of precision medicine in HEOR. But I think starting off with a clear definition of what precision medicine is, and I took this definition from a publication based on the personalized precision medicine special interest group within ISPOR. And I really quite like this definition because it explains what it is, the use of the molecular or other biomarkers or related algorithms. It talks about how is this used to characterize differential disease risk, severity, or ability to apply targeted treatment approaches. But it also talk about the who as well. And I think that's really important to define with these interventions and applications and the use of these technologies for a defined population group of patients. Moving on, my whole PhD research is predominantly about blood cancers. So what are blood cancers? Blood cancers, or otherwise known as hematological cancers, are a group of cancers that form when blood cells do not develop or function properly. Colloquially, I think that we understand blood cancers being either leukemia, lymphoma, and myeloma, but there are many different subtypes of blood cancers that exist under these broad umbrella terms. And in terms of the statistics globally, when you think about blood cancers as a collective, they are the fourth most commonly diagnosed cancer in 2020. And similarly as well, fourth leading cause of cancer mortality in the same year period. And in Australia, for patients diagnosed in 2018, the total lifetime economic cost of an Australian patient is estimated at $21.4 billion. And that was based on a report published by the Leukemia Foundation. So what are the two main key issues to the reimbursement and access challenges of precision medicine interventions for blood cancers? The first issue that I'd like to highlight is that there are inconsistencies to the coverage and access of genetic or genomic testing for blood cancers, particularly within the local context being in Australia. The Leukemia Foundation produced a survey and they found that 1 in 3 patients with a blood cancer had a genetic or genomic test to confirm their diagnosis, and even less so, 1 in 5 patients with a blood cancer had a genetic or genomic test to inform treatment selection. So it does highlight that there is some unmet needs for new technologies to assist and support clinical management of patients. And particularly with the Australian context as well, access to these genomic testing or next generation sequencing technologies, as well as the associated therapies, is largely achieved by either compassionate access, enrollment to clinical trials, as you just say, jurisdiction-specific or hospital-specific funding schemes, insurance coverage, or private funding. So by and large, these technologies have yet to be nationally publicly funded on the health system. The other key issue that I like to talk about is the health economic evidence of genetic and genomic testing for blood cancers is important, but limited. This particular issue was informed by a recent systematic review that we performed, whereby we looked at the health economic evidence of the use of these precision medicine interventions. And we found that there are a limited number of studies for the cost and cost effectiveness of genetic and genomic testing for the clinical management of blood cancer patients published in the last decade. Based on our data extraction and with the limited number of studies, there are a lack of incentives to really drive the health economic evidence generation within this particular space. And there are multiple factors that may underlie this particular point here, such as small market sizes, particularly when you consider individual blood cancers being quite rare diseases, high drug prices, especially with novel targeted treatments, high health economic outcomes above the payer's willingness to pay in the cost effectiveness studies, issues with evaluation design and data acquisition, which is probably not just for hematological malignancies or blood cancers, and in a lot of other cancers and rare diseases as well. As well as a shortage of health economic research for NGS technologies despite its clinical utility. So all this together really highlights the point that many applications of precision medicine interventions for blood cancers have yet to be investigated for its health economic impact. So now I'd like to talk about a recent cost-effectiveness study on precision medicine treatment for chronic lymphocytic leukemia, hopefully to add on to the health economic evidence base in this well-needed area of research. So a brief overview of CLL. It is the most common type of leukemia in adults, particularly in Western countries. And the clinical course for CLL varies considerably between patients, such as some patients can go through periods of time being asymptomatic, whereas other patients may require early intervention. With regards to the treatment algorithm, the standard frontline treatment for CLL consists of either systemic chemotherapies or multi-agent chemoimmunotherapies. And there is a growing appreciation for quite some time the value of prognostic markers for the early stratification of a disease. And there are 3 that are really quite relevant in this particular space. The first one being deletion 17p, detected by FISH, and patients harboring deletion 17p have an unfavorable prognosis. And the other one includes mutations in the TB3 gene, as well as the IGHV unmutated, such as patients harboring the mutation in TB3 or are IGHV unmutated have unfavorable prognosis. And consequently, the testing of the TB3 aberrations, inclusive of the deletions of the 17p and mutations, as well as the IGHV mutation status, have been recommended by multiple clinical guidelines, including the International Workshop of Chronic Lymphocytic Leukemia. So what does that look like in terms of treatment stratification? So in a risk assessment for CLL, Low risk includes patients with a TB3 wild type and IHHV mutated, whereby patients respond more appropriately to chemoimmunotherapy, such as the regimen of fludarabine, cyclophosphamide, and rituximab, otherwise known as FCR. Conversely, on the other side, patients with TB3 aberrations, inclusive of deletions and mutations, as well as the iron mutated IGV, are high risk and are better suited for other novel targeted therapies, such as ibrutinib. So what is ibrutinib? Ibrutinib is a Bruton's tyrosine kinase inhibitor, which was first FDA approved in the US for the frontline treatment back in March 2016. And it was predominantly based on major clinical trials, but there have been several other clinical trials since then that have supported superior survival advantage for ibrutinib-based regimens, either as a single or a multi-agent, compared to chemotherapy or chemoimmunotherapies within the frontline treatment setting. And importantly as well, survival benefit of ibrutinib is observed in patients with high-risk CRL. So looking at from the policy perspective, the reimbursement and coverage of ibrutinib, in Australia, the Health Technology Assessment, being the Pharmaceutical Benefits Advisory Committee, or PBAC, have approved for the frontline ibrutinib, specifically for the deletion 17p cohort back in November 2019. In the UK, the National Institute for Health and Care Excellence approved ibrutinib for deletion 17p and the TB3 mutation group in January 2017. And in Canada, the Canadian Agency for Drugs and Technologies in Health took a bit of a broader definition of approving frontline ibrutinib for whom fludarabine-based treatment is considered inappropriate. So there's currently limited health economic evidence for the value of the IHHV mutational setting on the frontline therapy decisions. And this will have implications for both the diagnostic and the treatment of CRL. So that was the rationale of our particular study, where we looked, where the objective of our study is to evaluate the cost utility of several different molecular testing scenarios for the characterization of both the TB3 aberrations and the IHHV mutation status for the first line treatment selection of ibrutinib in patients with CRL. I would now like to talk about the model and what we did. So we are looking into evaluating these scenarios in a hypothetical CR cohort of a young cohort fit patients with active disease. And we are evaluating 3 different strategies in our model. The first strategy, whereby we're looking at testing for deletion 17p only. The second strategy builds on that to consider TB3 aberrations, so the mutations and deletions. And the third strategy builds on that once further by including the IHHV mutations as well. And the perspective that we took is from the Australian healthcare system adopting a lifetime horizon. Our health economic model is a 2-part decision analytic model, consisting first of a decision tree for the purpose of allocating our hypothetical cohort of patients into one of the 3 strategies, not 4, my apologies. And the second part being a partition survival model used to evaluate the long-term consequences of the treatment choices. So this is a decision tree that we're looking at, starting off with a decision node with the first strategy of deletion 17p only, whereby patients with the deletion 17p goes on to receive ibrutinib, and patients without or a wild type TB3 receive SCR. It was important for our model also to consider the proportion of patients who may have mutations in the TB3 in the absence of deletion 17p that would have otherwise received ibrutinib, but under this particular strategy, they received SCR instead. So furthermore, strategy 2, testing for TB3 aberrations, splitting into patients to either ibrutinib or SCR based on their high risk profile. And strategy 3, including the IHHV mutations, similar as well. So including the if patients are TB3 wild type and IHHV are mutated, they go on to receive ibrutinib, otherwise SCR treatment. The partition survival model follows a 3-stage model commonly used in oncology, being progression-free, progressive disease, and death, whereby patients start off in progression-free and move on to the health states over time. It was also important in our model to consider substates being patients within progression-free and progressive disease with treatment and without treatment. And that was to account for the different regimens of ongoing treatment versus fixed treatment in our model. The model inputs, so in terms of model inputs, molecular prevalence, health state utilities and costs were derived from literature and publicly available data sources. And the state membership for our patient survival model were estimated from indirect treatment comparisons and survival curves from the literature. So with the indirect treatment comparison, what we did was that we had looked at the literature to identify studies, randomized control studies with the treatment and genomic groups of interest represented by those nodes, with a link denoting a study between the two comparisons. And we chose the anchor treatment, or the treatment with the common comparator being the FCR in the TP3 wild type, irrespective of the IHH3 mutation status. And our model outcomes were incremental cost-effectiveness ratio, net monetary health benefit, willingness to pay of $50,000 per quality adjusted life years. So in terms of the results itself, the mean cost and mean quality per patient is shown below, with the incremental cost effectiveness ratio for strategy 2 being $145,000 per quality adjusted life years, and the ISPOR for strategy 3 being $69,000 per quality. Based on these results, we rule out strategy 2 as it's being externally dominated, and we recalculate the ISA for strategy 3, estimated at $74,000 per quality adjusted life years when compared to strategy number 1. With the determinant sensitivity analysis, these are just the top results that are shown. Conscious of time, and what we see from this particular sensitivity analysis is that the long-term treatment survival, as well as the prevalence of molecular aberrations and the cost of novel treatment, having an impact on the model. And as for the probabilistic analysis, at the threshold of $50,000 per quality adjusted life years, strategy 3 is not considered cost effective under that particular threshold, but moving from a willingness to pay greater than $50,000, the probability of strategy 3 being cost effective increases. So in summary, the health economic model was developed to project the clinical and economic outcomes of TP3 aberrations and IHH3 mutation testing for the treatment of CRL. The health economic model demonstrated that the frontline treatment for patients with these prognostic markers offers more quality adjusted life years gain compared to when testing for lesion-sensitive P is done alone. Both of these markers is likely cost effective if a higher willingness to pay threshold is adopted, and the range in projected long-term survival reflected uncertainty owing to the limited clinical data that we use to model the participant survival model. And this study has implications for the implementation of precision medicine diagnostic services into routine clinical management. And I'd like to end by some acknowledgements with my supervisors, Professor Martin Eisenman and Dr. Kim Diggerling, Associate Professor David Westerman, Dr. Peter Bloomberry, and Dr. Ella Thompson. And I thank you for your time and look forward to taking questions later on. Thank you.
Great, thanks so much, Martin, for a really interesting presentation. It's very interesting to see the Australian perspective, I suppose, for us working in Ireland.